Can you hear me? Hi. Since we're doing something a little bit different this morning, if you're in the room, if you could kind of come to the two main sections over here, I think it'll make it a much more interesting panel. We're waiting for our moderator who had a little slip up on time. We're going to start at 10:30 and we're going to go for an hour. We would really love to have everybody sort of come to the two main sections. We think it'll make it a much more intimate setting. Are you guys having a good time? You didn't know I absolutely hate to speak in public. Thank you. Sometimes you just have to get uncomfortable in order to get your recovery. Was anybody in the women's conference yesterday? I loved when she talked about that. I thought, oh, that's what I've been doing all these years. Getting a little uncomfortable to get into my recovery. We thank your patience this morning. You can let it. You gonna put her in the middle? No, not here. That works. Rob, why don't you sit here?
Awesome. Thanks, Jason.
You're gonna put Yvette in the middle.
Wesley Clark. Yeah.
I'm a mess.
She's been retired for 4 or 5 years now from Samson. So
take a minute.
Yeah.
Take a minute.
Oh, you are. He's had a rough go at it.
Well,
You've been sick.
well, good morning again, everyone. Thank you for joining us. One of the most important things I think we need to talk about is really the landscape of recovery and how that is really ever changing. And so I'm really grateful that we have a very distinguished panel to talk about that information and to lead that. We are gracious and proud to have Yvette Torres, who will be moderating the panel. So with that, I'll give you Yvette.
Good morning, Oxford family. How are you? It's been a year since I haven't seen you. You know why I'm stalling a little bit? I just ran from my room. And you know what? The old gray mare ain't what she used to be. I could be able to do that and breeze through and speak. But anyway, today we have a tremendously auspicious panel. And I was not given their bios, but I'm sure everybody, it's in the book, I've been told. So
You want us to introduce?
we're going to talk about today. Do you want to introduce yourselves real quick?
Happy to.
Okay.
Who?
Tom, 2 minutes or one.
Well, I probably need the least introduction because I got introduced earlier and spoke, but my name's Tom Coder. I'm the Principal Deputy Assistant Secretary at SAMHSA and a person in long-term recovery. It's great to be with you guys today.
There you go.
Good morning, everyone. Good morning. I'm Barbara Bazron. I'm the Director of the Department of Behavioral Health in the District of Columbia, and I am formerly the Assistant Secretary for Behavioral Health for the state of Maryland. And I am delighted to be here. I have been an Oxford fan for many, many, many years and made sure that there were resources to support that living environment. So thank you for having me.
Thank you, Barbara.
Morning, everybody. It's great to see you all again. Been a couple of years. I'm Kevin Sabet. I was a senior advisor the most recently in the Obama administration until 2011, and then about a year after that, I founded a group called SAM, Smart Approaches to Marijuana, which is an issue a lot of people don't want to talk about. It's a kind of an elephant in the room, I think, in this field. Of course, the smart approach to marijuana is not to use it, but a lot of people forget about that. But we're also founded the Foundation for Drug Policy Solutions, which is really trying to take the mantra of meet people where they're at, but make it a lot better, because we want to meet people where they're at, but not leave them where they're at. And Oxford House is an awesome example of that. So thank
Absolutely.
you all for what you do. Last thing I like to say, I got my PhD at Oxford, but I get my education at this Oxford from all of you. So thank you all.
Kevin, thank you. Rob?
Hi, good morning. My name's Rob Morrison. I serve as Executive Director of the National Association of State Alcohol and Drug Agency Directors. Dr. Bazron is an esteemed member and leader. I am a family member of a person in long-term recovery, and that has been a journey that really I've been helped with from Oxford House. I was with Kathleen Gibson, and one of my first site visits, a woman named Flo Stein in North Carolina tugged me on my ear and said, "You're coming down and seeing how this works." And that was about 25 years ago. So thank you for educating me and helping me and our family.
Thank you, Rob. Okay, guys, the first question we're going to be dealing with is really how has the recovery movement evolved? And part two of that question is where it should be headed. You know, what kind of policy areas should we be looking at? We heard this morning from Tom about harm reduction. Well, how does that sit in with the Oxford House model, and so on and so forth? So, Tom, you want to kick us off? And by the way, this is like a panel where everybody's going to be able to chime in. If you hear that Tom has said something and you've got something to add, you can add, or Rob or Kevin, you can, or Barbara can chime right in. Go ahead, Tom.
We're going to have a conversation.
A conversation.
That's wonderful. I love it. So this, obviously, there's been a lot of evolution in this field. Particularly, you know, I've had the opportunity to see this over the last 20 years, and I try to kind of segment it in 5-year portions. And, you know, Yvette, a shout out to Yvette. Yvette, I usually call her the mother of Recovery Month because she, SAMHSA gave birth to Recovery Month 35 years ago, and Yvette kept it alive for all her time when she was at SAMHSA and in the federal government. So thank you, Yvette, for all the work that you did on Recovery Month. But that was a big deal. It was a big deal for people to do these celebrations during Recovery Month, to be public about their Recovery Month, their own personal recovery during Recovery Month. As we all know, addiction was seen for a long, long time as a moral failing.
That's right.
And Recovery Month helped change that. Recovery Month helped people come out of the woodwork and say, I'm in recovery, and my life has changed dramatically as a result. It was no longer a mark of shame to be in recovery, which is great. We now view these conditions as conditions, not as weaknesses, and we view them as treatable conditions, which is great, with less stigma and less negative public attitudes around them. Do we still have work to do? Of course we do. But in those 5-year increments, each of those 5-year increments, I've seen a dramatic change in the way people view addiction recovery. And now, in this last 5-year period, we've been presented with this dilemma of this more potent drug supply. And so we've had to continue to evolve and think about things differently. We've had to start thinking about how do we keep people alive. And so a change in policy has been necessary to do that. And Yvette mentioned harm reduction. That's one of the strategies for engagement. But we at SAMHSA believe that it's really important to build recovery capital in all facets of people's lives. And I mentioned it when I spoke this morning about health, home, purpose, and community, the 4 dimensions for life and recovery. That's been incredibly important for us. And we're, as I mentioned, also exploring the idea of next generation ROSC, recovery-oriented systems of care, as CC built out beautifully, this recovery ecosystem model, recovery-ready communities. I think that's all part of the evolution of this landscape.
Tom, I have a follow-up, if I may. Given that SAMHSA was also tasked to a certain extent, work with NIDA, National Institute of Drug Abuse, to develop policies based on the research that NIDA does. How is that going? I mean, is that something that's still viable, or?
Yeah, no, we work very closely with our federal partners, especially at NIH, to make sure that the work that we're doing is evidence-based, is sound, right? And so the science really is what we're allowing to drive us. And when anyone talks to me about being opposed to things like harm reduction, we point to the body of science that exists, decades, by the way, of science that exists in that area, that really, the practice really needed to catch up to the science in that case. A lot of times the science has to catch up to the practice, but in that case, it was the reverse. And so, yes, we continue to work very closely.
Right. Barbara.
Yes, I've been in the field probably for at least 30 years or more. And during that time, I have really watched this evolution. And I remember when I first started in the field, therapeutic communities was the gold standard back then. Just Say No was the policy framework that was used by the federal government. And its natural leadership, and the self-help movement was really well underway. Now, today, I think that I am very pleased to say that the self-help movement has continued to evolve, with our peer partners being recognized as one of the most essential elements in the system of care. We within the District of Columbia certify individuals with lived experience. We feel that we have to do that because you have walked the walk, talked the talk, and you know best how we should move forward, and it's something that I really do support. Now we know that substance use disorders are chronic relapsing diseases. We can't blame the victim. We do not blame the victim. That is not the strategy that we're using. And now one of our goals, as Tom said earlier, is to keep people alive. You've got to keep people alive until they're ready to take the recovery journey. And we do that through harm reduction, which includes naloxone, as well as things like our stabilization center, which I'd like to share information with you about a little later, and other low barrier opportunities, vending machines, and so forth.
Very good. Kevin.
No, thank you. No, I appreciate those comments. And I guess as the one person, well, Rob doesn't either, but sort of in a sense, but who's not connected to the government, I feel like I can say things that I probably couldn't say. Tom would have gotten me in trouble 10 years ago if I said it now. He just said, I can be a little bit unleashed, which I don't know if that's good or bad. But I think harm reduction presents an incredible opportunity for us to learn, but it also can present a threat to recovery, and I'm saying that. What do I mean by that? What I mean by that is it's really important to define what we mean, which I really love. Barbara just did that when it comes to harm reduction. I've been in this field since I was 14 years old in prevention, so that was a long time ago. And when I went to my first conference and they started talking about harm reduction, they talked about safe ways to use drugs. They talked about teaching kids not with people in recovery, but with people who can use drugs and live a good life, and show them that there was a safe way to use heroin. There was a safe way to use cocaine. And I'm here to tell you there's no safe way to use drugs. And so, but harm reduction when it comes to things like naloxone, when it comes to the things that I'm very grateful for SAMHSA for defining. And this administration, and I've been critical about a lot of things, you know, whatever administration it is. That's why I never get invited back to the White House. I guess maybe that's why. But I will give them credit here big time because they have defined it. What is not helpful is when people who want to normalize, commercialize, legalize, promote, profit from drug use and continue drug use in society take the good intentions of people working in harm reduction, which is about outreach. It's about, you know, this is a continuum, but it's about those folks at the end of the continuum trying to engage with them because the other things we couldn't engage them with, they didn't work. We don't want to give up on anybody. That's what harm reduction is about. But what I don't like is when I see people with other motives who want to normalize drug use basically usurp harm reduction, which is what many of them have done, and to say that in the name of harm reduction, we're going to have a place where people should, and we encourage them to use drugs. In the name of harm reduction, we're not going to really incentivize you to get help, so we hate drug courts, we hate South Dakota 24/7 sobriety programs, we hate Hope probation, we hate anything that's going to kind of nudge you to get treatment. We don't like it because we have to wait for you to want to get help. Folks, if we're going to wait for the tens of millions of people who have this disease to get help, we're going to be waiting a very long time. This is a disease that hijacks the brain. Why would you want to stop? It feels great. And yes, 40% of people in recovery did so through treatment, but 60% did so not through treatment. They did it through informal ways. They did it because their girlfriend was going to kick them out of the house. And that changed their behavior. They did it because they were going to lose their kids, and that changed their behavior. We don't want it to get to that, of course, but sometimes it does. That's why this disease is very different than other diseases. That's why I totally believe in the disease model, but we have to be very careful when we think of it as any other disease. This is a disease where you lie to your grandma. You don't lie to your grandma when you have diabetes. You don't steal from your mom when you have cancer. So this is a different kind of disease. It's a biobehavioral disorder. It reacts to the environment. It reacts to if people around you are saying, yeah, here's a safe, quote unquote, place to use. Here you go. And where I live partly in Vancouver, now they're giving hydromorphone, OxyContin to people who are opioid addicts because they think that's going to help them not want to use fentanyl. What is it doing? They're selling it to kids so that they can get the money to go buy fentanyl. So, and that's called safe supply, safe again. So
Kevin,
I think we have to make the distinction.
Let me interject. What kind of policies then ought to be developed as we look towards the future in regards to what you've just presented?
Well, no, I mean, I think definitely we want to keep, obviously naloxone is vital. It's an incredible advancement. We need to make sure everyone has it, in an easy way. Treatment has to be on demand and it has to be affordable. We have to have proportionality in our criminal justice system because sometimes we've gone way overboard and not treated this like a health and safety issue. By the way, it's a health and safety issue. It's actually both. So, but we've gotten overboard. So we need to have correct criminal justice reform. We have to reform our whole probation and parole program. It's completely broken. And that's where 70% of people have an addiction. So that's a place to start, right? And we need to expand opportunities like Oxford House and those things.
Right.
All right, thank you, Kevin. Yes,
Yeah,
Barbara?
I wanted to add to that because I think there are a couple of things around harm reduction that we should really emphasize. Low barrier access to care is so important. What we have found in the District of Columbia as we've created our first stabilization center, and I'm using that language very carefully and very specifically, it's a stabilization center where people can go 24/7. They can, when they are inebriated, to sober, to get medical care, to get connected to a peer partner and begin to have the discussion in terms of whether or not they are interested in moving into recovery. People can come as many times as they want, as many times as they want. We have one gentleman who's been there 100 times. 100 times.
And the door is still kept open.
And on that 100th visit, which by the way happened this past Tuesday, he said, "I'm ready. I want to make that journey to recovery." And that's great. And of the, just one other fact, of the almost 5,000 visits that we've had, 1,833 unique individuals have come into the center, and 23% of them have made that decision to move into recovery.
Fabulous, fabulous. Rob, I want to hear from you.
One question you asked, and that was, how has things changed? And so for me, a lot of what I do is go to Capitol Hill and meet with offices and help educate them about the system and some policy initiatives, some funding that would be helpful at the federal level. And I'm sitting up here with a former legislator, so this is dangerous. Tom served in the state legislature and knows this very well. But one thing that's changed is a dedication to substance use disorders as an important part of their policy portfolio in these offices. When I initially went, first, this was in 1998, it was hard to get a meeting at all. I want to come in and talk about addiction treatment. We'll check back in and call you. When we did get a meeting, we would get two staffers. One worked on criminal justice and the other on health, and they would come in sometimes chuckling, saying, "We brought in our folks who deal with guns and drugs." This is real stuff. Over time now, you all, so many people out there pressing for policies that you want to see move, including Oxford House and resources for Oxford House. That's important. It doesn't get done by other people speaking for you. It gets done by you speaking for you. And you need that. I think I've also seen more people who are not in recovery shut up and listen and go into the rooms and be there for their family, because they're getting taught up by you all, and I'm one of them. I told you I'm a person with a family member who's in long-term recovery. I was their step-down program. My basement was kind of cold, but it worked out because she couldn't find housing. That's why. When she was ready for the next step, it wasn't available. And we live about 10 miles from Washington, D.C. I go to work every day 4 blocks from the White House. I was 2 blocks from Kevin. I couldn't get my family member housing. So we have a long way to go, but it's much better. But this Thanksgiving, I had a reminder as I was calling my family and seeing where people were going to be and where their plans were going to take them. One family member wasn't answering. I kept texting and texting. Finally, I get a text back. "I can't talk right now. Paramedics are here." I get another text saying, "I don't know how to say this, but he's gone." And another family died. A family member didn't make it from the overdose crisis. And that's this divide between how far we've come and what we're still dealing with. And that's why we need you all to be very loud on what you recommend the federal government do, and get in the government. We have too many armchair folks like us sitting here giving free advice who are not in recovery. Tom is doing it. We need more of that, so thank you.
Rob, talk to us about current initiatives, legislative initiatives that you know of that deal with recovery and housing or other areas that we'll cover today.
So a couple things. Congress did move to provide more funds for states for prevention, treatment, and recovery. There's a big old block grant that's out there that's about $2 billion that goes to states and District of Columbia that gets diced out to providers, and that's an important resource. During COVID, Congress said we got to do something more to help more people in a lot of different areas. So on top of that $2 billion, they added another $1.6 billion to the block grant for more stuff for alcohol and drug services. And Oxford House is an allowable use of funds. Dr. Bazran will talk about her leadership on that. Well, 4 months later, Congress, a new administration came in and said, we want to do more stuff under the title of the ARPA, or the American Rescue or Recovery Plan, and they gave another $1.5 billion. The deadline to spend down those money, that money is coming up next year. So we're facing a fiscal cliff. There's no plan for another big installment that we just got. We basically got $3 billion over the last couple years, and now we're facing nothing. That's a problem.
Major.
So we need you all to help educate people on the investments, just like Uta talked about. I talked to her. I was in the room when she was saying, shoot, we have state opioid response grant money. We got to make sure we allocate this well. Because the Hill rings up Tom and says, Tom, what are you doing with that money? We need to know. So we work as states, DC, to educate people on the data. So I would say that is numero uno, and then making sure that right now there's legislation out there that says we should promote models and TA around recovery housing, right? What about money for recovery housing? Straight up.
That's the issue. Okay.
Yeah,
Do you have anything to add, Barbara?
Yes, I think there are a couple of other things legislatively that have made a difference. One of them has been the change in the requirement for who can induce individuals. Before, if you remember, a physician or a medically trained person had to go through a training program before they could induce someone who wanted to move into recovery. That waiver requirement has been removed. That's one thing. The other thing is that our fire and emergency medical services can now do induction in the field mobily. So, and that was also a change in terms of the ability to do that. Somebody is there, they've just been revived, they indicate, hey, you know, I really want to move into recovery, rather than then have to go and be taken someplace else and go through a long process. Fire and EMS can do it right then. And then the third thing is that there is more flexibility in terms of providing services behind the wall. Services to people who are in jail and prison. Within the District of Columbia, we have a specialized unit for women, a specialized unit for men, so that they can get all three forms of MAT while they are incarcerated. And as they step down, we provide them with naloxone, with a prescription, and with a connection to care. Those are the kinds of changes in the environment that I think have allowed us to keep people alive and to maintain their recovery.
And do you also include housing in that referral process?
Absolutely. We have both 31 Oxford houses within the District of Columbia, and we also have environmental stability housing that's funded through our state opioid response grant. And we really are looking at the National Association of Recovery Residence Standards so that we can begin to have that whole continuum of housing. Some people need more support, others need less support. Let's give people what they need, meet them where they are.
Tom.
Yeah, just excellent.
Yeah.
Yeah, in addition to these unprecedented resources that Rob spoke about and the threat of them disappearing and going away and creating that cliff, we also have to have better policies, right? So this is kind of a both and thing. You need resources and you need policies. So we have been working very closely with our friends at CMS, for instance, around how you can spend Medicaid dollars differently to support these kinds of spend Medicaid dollars because that's the largest pot of money that's out there. You know, the pot that Rob talked about, the block grant, is the largest pot that the field has, but oftentimes we forget about Medicaid, which is, you know, since Medicaid expansion, that's the largest expansion of treatment services. It's the largest expansion of recovery services in the history of our country. So those policies matter. Barbara mentioned behind the walls, changing criminal justice policies. We are working with our colleagues at HUD. We talked about public housing, for instance. HUD released a rule earlier this year that changed the way discrimination based on having a criminal offense or around a drug addiction or mental illness is preventing people from getting into public housing. So these are things that are better policies that are changing. How many of you, your houses took advantage of like the revolving loan fund to set up your house? How many? Just show of hands. Yeah, lots of people. That was an instance of an idea that came about that didn't, maybe Rob has some more of the history of it, but an idea that came about that didn't create a lot of money, it didn't cost a lot of money. Yeah, probably from Paul, right? Paul in the old guard here at Oxford House said, if you give us this money, we'll do good by it. And you won't have to give it to us every year. We'll use it every year. We'll just keep recycling it. And I saw in the Oxford House manual that it was in everyone's bag. I won't read the alcoholics and drug part, but it says an idea based on a sound system for people in recovery to help themselves. And so to the extent, as Rob's talking about, you can show public officials, legislators, policymakers that these policies not only make sense, but they're cost effective, you're going to be able to get a lot.
But Tom, I think one of the issues is that there was a study done, maybe 20 years ago on the Oxford houses by a university in California, and it showed tremendous success of the Oxford houses. Since then, we really have not had any type of in-depth study
Of the model.
because, number one, we now have 3,900 Oxford houses all over the country. And before I continue, you know, Paul's dream was 10,000 houses.
Right.
Yeah.
And I don't want any of you to forget that. Okay? So how is it that we are going to be able to present to legislators or present to SAMHSA or to the District of Columbia the success of these houses if, in fact, we haven't studied it?
Yeah, so first I'll say is that study was really important, and it actually made it into the Surgeon General's report, the 2016 Surgeon General's report called Facing Addiction in America, where it showed the power and the proof of this model and called out Oxford House specifically with regard to that. So Oxford House's work, you guys know it, I know it, the research already says it. But to Yvette's point, yes, SAMHSA is not a research agency per se, but we can certainly talk to our colleagues at NIH about investing some of their resources potentially in doing some more randomized controlled trials and other kinds of gold standard evidence that proves the efficacy of this model. And not only the efficacy of the model, because as I said, the model's already been proven, but let's show people for long periods of time what has happened to them in their lives, right? This is something that we did also around the National Survey on Drug Use and Health. I remember going to a Recovery Month press conference event one year and being the kind of the recovery speaker at it. And I said, hey, this is all great that you guys are doing all this, collecting all this data about where we're using drugs, on what corner in America, at what time of day. That's all great information. Thanks for providing it. But when are we going to start collecting data about how people are recovering in America? And this is a similar question, right? And so we can potentially use surveillance. We call them surveillance tools. I'll just call it a data tool for the purposes of this crowd. But we can use data to really help tell that story. And we do have that within our authority. So maybe there's some ways that we can look at NISDA and asking questions in our household survey about people who have been in recovery housing.
If I can say something, yeah, I mean, we definitely need more evaluation. Of course, it matters how it's done. There's the old adage that says, if you want to kill a program, evaluate it. So we have to be careful. But I think clearly we need more data, especially on the updated models. But I think more importantly, we have to think about it. It's sort of cliched, but it is important. How do we change the whole systems while at the same time, how do we push our elected and other decision makers to really show leadership on this issue and use the power of the bully pulpit, actually, which is, I would say, as important as funding. Sometimes it doesn't pay the rent, but it does have a huge impact on attitudes, and and that's why what Tom's saying about policy is very important. We've seen a reduction now for the first time in a very long time in overdose deaths, which is awesome. But that's in the East Coast, South, and the Midwest. We've seen large increases still on the West Coast. Now, there are different reasons for that. Different people have different hypotheses. It's possible because fentanyl was in the East Coast first. It sort of cycled through. Fentanyl came to the West Coast later, and it just needs almost like a cycling through if you kind of look at historical patterns. But it's also very possible that our sort of macro policies in some of these states in the West, what did Oregon do 3 years ago, and so did Washington? And some people, what I'm about to say, what they did, voted for this and wanted this out of very good intentions because, like me, they don't want to see people with addictions criminalized for simply having a disease. So they voted for and passed full drug decriminalization. And it sounded great. It was called the Treatment and Decriminalization Act. It was supposed to get people into treatment. What did it do? It got nobody into treatment. It actually destabilized recovery housing. It skyrocketed the levels of use, also public use and disorder. And why public matters is because we need the public support for these kinds of recovery and innovative things. And if they see that when we quote unquote care about addiction, these bad things happen, we're going to lose public support for all the good things. And so we need to be very careful, again, not to have our movement, I would say, hijacked by the sort of extremists on either side. We don't want people thrown in prison. We don't want law enforcement, war on drugs. But on the other side, also, folks that are saying, in the name of not putting people in prison and increasing treatment, we're going to normalize and decriminalize drugs. And it goes back to stigma. It goes back to normalization. We don't want to stigmatize individuals ever for this because we want them to get help and be open about it. But it's a balance because we also don't want to normalize use and promote it as well. So it's thinking about the user versus the action, I think, is extremely important.
May I speak to the data question? And I think that at the state level, I have the benefit of being able to collect data around what works, what doesn't work, and why. And it's critical. You've got to be able to tell your story to the policymakers in order to continue to get the supports we need. So it's very important, and you got to do it as a system. I can't do it just as the Department of Behavioral Health. I have to connect with Medicaid, I have to connect with Fire and Emergency Medical Services, with Department of Housing, with Welfare, and so forth. And together, we have to develop that dashboard that provides us with the information. So I can tell our council, oh, by the way, since 2018, we have reversed 160,000 people using naloxone. Those are lives saved.
Absolutely. Congratulations. Rob, we have all of these soldiers here, recovery soldiers. What do they need to do? We've heard from Barbara, we've heard from Tom, we've heard from Kevin. You work with the states. Is it something that these individuals, these soldiers, are going to go and talk to the state offices, or where do we start in the process of getting them engaged in this dialogue?
Got it. So, as I mentioned before, Dr. Bazran's a member of our association. Our association is composed of the lead agencies who manage the alcohol and drug system in every state, territories as well. All are members. And it's their job. Dr. Bazran tells me all the time, that's my job to know who's in my state, the folks doing the work, the providers, people in recovery, people who need help. That's the job. So reaching out to the State Alcohol and Drug Agency, and there are other folks here. I saw Marissa from Louisiana. I think Chris Scalise from New Jersey is in the other session on reaching out to your state agency. And Tom worked in the state agency. He was a member for a good 3 months.
I am NASDAD alumni, believe it or not.
And they oversee the resources, they set the policy, they make sure, I really think the number one thing they do is make sure that service delivery is there, working with the providers and understanding how to make things better. And you need help getting to your state agency, that's my job, to get you back to the people who do the work at the state level, so connections can be made and resources can be allocated. So,
Yvette, we have an easy way for you guys to get involved. I mentioned it when I spoke this morning, but there's a session tomorrow morning at 8:15 where it's going to be a listening session. This information is going to go back to the work that's happening in this interagency work group on recovery housing that includes SAMHSA, HUD, and our friends at USAGE, the United States Interagency Council on Homelessness, where they're really interested in this recovery housing model and what they can do to improve it. So if you want to learn more, if you have thoughts, if you have opinions, get to that listening session tomorrow morning and really offer some opinions, because this is all going to be recorded and it's going to be transcribed and sent back to the working group, so that some of your ideas actually may end up in a federal government work plan at some point, and that'll be really important.
So Tom, how does SAMHSA, what's the word I'm looking for? And let me give you an example. Prevention. I know that SAMHSA has to do a fine dance between prevention, treatment for addiction, and mental health. CATCA, for example, has always been a worthy recipient of resources from SAMHSA, almost yearly, for example. So how does the housing, I know tomorrow you're going to have that session, and I think it's a great start, but are there ways for SAMHSA to almost cajole, encourage the states to use some of the resources towards the housing issue?
Well,
and self-help groups.
They do.
yeah, I'm sitting right here, Yvette.
You're talking about Rob in front of him. But the good news is that we're doing that already, Yvette. We published on our website allowable uses for the Substance Use Prevention Treatment Recovery Services Block Grant. So those allowable uses are there, and I think we just worked with NASDAD and our partners. We're about to publish a more in-depth guide about allowable recovery support expenditures. Guess what? Housing is on the list. Talks about recovery housing and supportive housing assistance being fundable, peer respite centers, temporary housing assistance, deposits, utility assistance, electricity, heating, internet. they're all deemed appropriate and allowable expenses for block grant. And so we've taken the time and the effort to go through all of this and to find out, because who was the guy that used to rob banks? Willie Horton, right? They asked him, why do you rob banks, Willie? And he said, because that's where the money is, right? So my right is smart. My advice to a lot of people is look for where the money is in the federal government. And the Substance Use Prevention Treatment Block Grant is a great source of funds. They're unrestricted, mostly unrestricted. But we have identified we've carved out a whole bunch of allowable expenses in your space that you can access those resources through folks like Barbara and Rob's other members. By working very closely with your state agency partners, you can really access states and counties depending on the state you live in.
Yeah, and I'd just like to say that they do tell us that to use our resources for housing. What we know is that when someone is in recovery, housing is one of the critical elements. And so you have to really address that issue. And that's why there's environmental stability housing that is supported through the State Opioid Response Grant. That's why we support Oxford housing. And that's why we use a blended funding mechanism to make sure that there's housing. We need to do much more, but at least we are on the path to try to do that. And then also one just slight correction, it's 16,000 naloxone reversals. I just want to make sure we got that clear, but still that's a lot of people who have been reversed.
Barbara, why don't you share with them how you in the District of Columbia, as a single state agency, support Oxford houses so they get an idea of what those houses in the District of Columbia are doing with your resources.
Oh, certainly. We have 31 houses in the District of Columbia. Paul had me on speed dial.
Yes.
For many years, and so I have been a supporter of Oxford housing in both of my roles, both in Maryland as well as within the District of Columbia. It is an essential support. We have over 300 people who are living currently in Oxford houses. We provide specific supports like making sure that we pay for housing managers, for care coordination, for other services and supports. And also within the district, we have something called free rides, so that anyone who needs to get to an appointment can get there free of charge. We will pick them up and we will take them there because we don't want that to be a barrier to care. One of the things that we also have had to do with, certainly during my term within the district, is we've had to work with neighbors and people in community who were a little fearful of having an Oxford house in their community. And really share the positive outcomes and the fact that this is going to be the best kept house you have on your block, not the worst. And that's the truth. And that's the way they look. I'm going to tell you, that makes a big, big difference when they can say, see, we have one here, one here, one here. What do those look like? Oh, we didn't know. Well, good. You need to know that people in recovery are good neighbors. And I think that's something that we all have to really make sure we emphasize. And thank you for being a good neighbor.
Excellent. I'm going to have some final thoughts of our panel. I think I covered everything that Jason and Kathleen asked me to do. They wanted to see what other models are available for housing, blah, blah, blah. I mean, it's Oxford House. Let's face it. So I'm going to allow, beginning with Tom, of a minute or so. And then I think we have 15 minutes for questions. So if you have any questions, the mics are before you in the middle. And you can ask us and the panel questions. Tom.
Thanks so much, Yvette, and thanks everybody. And it's just been a great panel. Thank you to Rob, and Kevin, and Barbara for all your work and your efforts. I think the only thing I haven't covered yet is our Office of Recovery. How many of you know that SAMHSA now has an Office of Recovery? Just had its second birthday. How many know about our Office of Recovery? Anybody? Oh, a couple people, great. We are using that office to really advance things that we haven't had the time to advance or the ability to focus on in the past in the recovery space. Sure, CSAT has done an amazing job of advancing recovery in the years prior to the office being established, and Yvette used to run the Consumer Affairs office in CSAT, which had that task. But when the two offices were kind of folded into this one office, it's really given us a dedicated staff with lived experience that have their ear to the ground and know what's happening. And it's given us a place to really focus on things like recovery housing. So we have been doing convenings, we have been publishing reports, we're doing the listening session tomorrow. There's all these activities that are happening in our Office of Recovery that revolve around recovery housing. So please see Donna tomorrow at that 8:15. Look her up. She's here at the convention today and tomorrow, as am I. If you want to get connected with our Office on Recovery or any of the activities we're doing, we would love you to be part of this journey with us.
Tom, before you go, can you talk more about the equity-oriented housing settings that you spoke about this morning and what that entails?
Well, you know, one of the things that the Biden-Harris administration has been focused like a laser beam on is trying to infuse equity across all of our programs. And so at SAMHSA, we have things like disparity impact statements that we require grantees to report on, to make sure that we're reaching into communities that, you know, into every community in a community, because we know that these issues disproportionately affect certain communities versus others, and they oftentimes are the least to receive our services. And so what we've been trying to do is really, from a data perspective, keep track of that, and then course correct when we see that there's an opportunity or when there's a place that we're not focused on. So that's what we're doing with that event.
Okay. Thank you. Barbara.
Okay. First of all, I am so delighted to be here and to be with you at this moment in time. I strongly believe in harm reduction. I strongly believe that you got to meet people where they are, provide them the resources that are needed so that they can make that recovery decision. I believe in Prochaska and DiClementi's work that says that, you know, change is a process, and we need to be there to support people as they move through that change. I also strongly believe that services have to be easily accessible. We have to be able to access services 24/7. People don't decide that they need service at 2 in the afternoon. Sometimes it's 2 in the morning. Sometimes it's 3, whenever it is, we need to be there to provide the support that people need. And lastly, I strongly believe that prevention, intervention, and treatment works, and recovery is possible for everyone.
Amen. Kevin.
From a policy point of view, I think we just always need to remind people that there is hope. And it's not just individuals with substance use disorders, but also lawmakers, that there are things that work. You are all examples of things that work. And when we start to get hopeless, it's when we start to get desperate. It's when we start to really implement policies that are completely counterproductive, policies that in the long run are killing people, and then in the long run are not letting people live a life worth living. Because you absolutely need to be alive to get treatment, but we want you to live a life worth living. Because the question we have to ask our lawmakers and leaders are, you know, what do we do after naloxone? What's the plan? Because absolutely, let's revive millions of people, but we need to have a plan and we need to have systems in place for them to go to. Otherwise, they're not living a life worth living. And then we get the statistic like 15% of people reversed with naloxone last year died within a year. That's a complete failure on the part of our systems to remember that this is a biobehavioral disorder. We cannot always wait for people to want help. We have to nudge them in the right direction with love and compassion. On the process side of this, we need your voice. You are all those soldiers, and we need your voice, because the voices of those that have profit motives, that have other, frankly, justifying their own substance use, unfortunately, those voices are also very loud. And they have very deep pockets, and they're going state by state to change policies. They did it with marijuana. I'm going to talk about it this afternoon. They're doing it with psychedelics now. All of a sudden, psychedelics are the new thing. I mean, just out of nowhere.
Or depression.
And they're doing it with other drugs. They're doing it with opioids, safe supply, etc. We need your voices. If you go to gooddrugpolicy.org, that's our foundation policy, drug policy think and do tank, which we started with former Congressman Patrick Kennedy. Go to gooddrugpolicy.org, sign up, get involved, because we need you in your states to advocate for Oxford House and to advocate for those policies that enable people to be successful in Oxford House. Thank you all.
Thank you, Kevin. Rob.
Sure. If we talked about state agencies earlier, I'll just give you our webpage to sign up for updates that go out weekly, and then you can find me on the staff tab if you're looking to connect with your state agency. So that's NASADAD, NASADAD, so www.N as in Nancy, A, S as in Sam, A, D as in dog, A, D as in dog, .org. And I'll connect you. And it could be that you get connected to a staff member who focuses on housing or whatever it is the issue is there. I'll end with, you talked about the need for research. I think we do need research, because if I go in and give a Hill office a literature from 2010, it's good. They say, you got anything more recent?
Yes.
All the time. I also say that, the recovery community was key in, I think, and this is what we need to research, for the overdose, I think, bending the curve, because often, to answer, to help partially address what we hear, as Kevin pointed out, what next? The what next was really illustrated early in Rhode Island, when the recovery community was mobilized to go in after someone overdosed, to the hospital, to the setting, to be there to help with whatever it is that person needed, something more. And we know the data showed something more some went to treatment, others found housing, some went to meetings, and eventually got more. That was involving the recovery community in the solution. And I thought that was critical, and a model came from, yes, I admit, Rhode Island, where you're from. So thanks for letting me be here, and thanks for teaching me up. I love this meeting, and I appreciate you.
All right, it is now, we have about a couple of minutes, and I need for some folks to ask questions. I think we have about 3. You have to go to the mic. Please go to the middle and go to the mic. And those of you that are leaving, please fill out the evaluation for the panel, because I don't think we've done a panel like this before, and if you liked it, let them know.
Okay, hello. So I just recently began my journey into the peer support specialist field. And my big question is on harm reduction as a whole, because I think harm reduction for me as a recovery pathway doesn't really make a whole lot of sense. I get the medication part where the naloxone is in, but I feel like, I don't know, my question to you is, can harm reduction focus more on, less on safe use and more on providing jobs, providing a way for these people that are coming out of addiction to re-enter society? Wouldn't that be a better harm reduction pathway or recovery pathway than talking about safely using it?
You can vote.
Well, thank you for your question. And, not to answer it directly, but just to pick up on something Kevin mentioned earlier, SAMHSA developed a harm reduction framework with a definition of harm reduction, core pillars, principles, and actions that you can take in your local communities. I think it would speak exactly to your question and be able to help you in your own advocacy to try to figure out where harm reduction policies actually fit into to what you're doing in your local community. But I don't want to take up all the time, Barbara.
Oh, no, I do agree with you. And first of all, I think supported employment and other kinds of services are really critical. Kind of help people, okay, what does my life need to be like now? And how am I going to survive within this new framework and this new environment? So we have supported employment for individuals who are in recovery or who have substance use disorders as well as mental health disorders. And it is a Medicaid billable service, which we really appreciate. And we work very closely with other agencies like RSA so that the additional funds are available. So I think that's important. The other thing, to me, harm reduction is meeting people where they are and providing them with the supports they need as they move to improve their life circumstances.
You can
Very good.
define harm reduction the way you need to define it. And it can either be a big tension, I think this is a critical question, or it can be actually not be a tension. It doesn't have to be a false dichotomy between harm reduction and recovery. Now, folks that want to have safe use and legalized drugs, they do want that false dichotomy because they want to say harm reduction good, recovery not as good, or incidental. Like recovery, like if it happens, great, but not the goal. You
Yep.
can make it the goal.
But Kevin, I think that the issue is that the soldiers and the folks here have to work with their state agencies, with their local government, to make sure using the guidelines
yeah,
from
don't
SAMHSA
recreate the wheel.
to
Don't
be able to frame it in a way that is acceptable.
You have it there.
There's
so
a
on.
there's a
Can we get to
but,
another?
yeah,
one
definitely.
More
But I just
question?
wanted one other thing: pathway to recovery, or pathway of recovery.
Perfect.
So I think you need to think that through.
Very good.
One more question, I think, or maybe two, if we're quick.
Hello, my name's Joshua. I'm an addict. So in the Oxford house I'm at, we've had a lot of bringing people in from treatment centers. And a lot of the problems that they're having is not having IDs to get job placements and things. I was wondering, with some of the funding you guys have, could you create an Oxford House treatment center where people go and actually begin the process of learning the Oxford House model and getting an ID, and then, like she said, learning how to do the job placements. We have Oxford House guys in North Carolina with a resume building program on our Oxford page. There's all kinds of things we could implement in the Oxford House Treatment Center if there was to be one.
I saw a recent. I got to go to Alberta, Canada, who's doing something different than Vancouver's doing, and they have a whole Recovery Alberta model, and part of their Recovery Alberta model was to help people who were on the streets in different cities, the big cities in Alberta, to get into housing. And they opened up these things called welcome centers, and that's exactly what they did there. They provided identification, they provided other services, one-stop shopping. I think certain cities in the United States have done that, certain states have done it, but we've got a lot more work to do there.
All right, one more question? Maybe
I'm-
two. If you,
I'm Dre. I'm a recovering alcoholic and an addict. I am eternally grateful to Oxford for saving my life. And I was just wondering, what do you guys think is the best way for me to give back to the people that aren't in recovery yet? Like, how can I reach them and help them?
You're doing it. You're doing it. You're here. You're here at this convention learning about how to be of service to Oxford House. That will open up doors for people just like yourself to find this pathway. So keep doing what you're doing.
and just talk to everyone about your success. I think there's no better proof of success than an example through your own experience. Sir, go ahead.
Yeah, my name's Joey. I am one of those certified peer family support specialists, and I have noticed there's one guy in particular where he doesn't subscribe to the concept of having any sort of addiction. He said, the only addiction that I really have is, I really don't want to wake up tomorrow. It's suicidal ideation, right? And I started thinking about that, and I realized, yeah, I remember staring into the void. I remember sitting on top of a roof, contemplating whether or not a breeze or I was going to jump off. That was something I was addicted to get rid of the pain, right? The substance use was the reason that it got to the pain, and the pain ended up getting bigger. But I also realized there was no really recovery pathway. There was nothing medically, other than like the clinical 72-hour hold, right? I didn't see any sort of grief groups. I did see a couple, but they were paid for. You had to pay for them. There wasn't really anything that I saw as far as Medicaid related or anything state funded that I could help this man find a group of people that he related to, that he was able to build a community with, which builds that connection that gets him out of that hole of not wanting to wake up tomorrow.
Which state are you from?
Colorado. So there's literally, I've only found one facility as far as like a group thing. So what is the, help me find something. Not specifically for Colorado, but can you point me in any directions?
Sounds like an advocacy opportunity potentially, right? To share kind of that story and the lack of resources with your local folks to identify if this is a one-off case, perhaps they can find some type of place where he would fit. But if it's a bigger problem, developing those kinds of spaces could be something that you could help advocate for.
Yeah, and I'm happy to connect you to the
State
national
folks.
level groups that focus on suicide, and just was emailing with her today. So we can connect on both levels, Colorado and then the national.
Thank you,
and
Rob.
remember our 988 lifeline, right? It's our
988
suicide and crisis lifeline.
suicide hotline.
No, they're not. They're not getting rid of it. Yeah, they're not getting rid of it. No. So we'll happy to talk afterwards about it.
All right, folks, thank you so much. Thank you for your patience in waiting for me, and God bless you.
Let's give them a big round. Thank you so much. Your next
Thank
session
you, Tom.
starts at
Thank you,
11:45.
Barbara. Thank you, Kevin. Thank you, Rob.
Thank you.